We have a very interesting discussion. We have a panel discussion now for about an hour or so. And in that panel discussion, we will take you through imaging-based genetic testing in the first trimester. And then I can hear those people who do only imaging. Why? Why are you taking me through this? I will send the patient back. The fact is that a lot of imaging is now quite different from a lot of imaging otherwise if you don't know genetics. And we have to change and adapt the protocols accordingly, and we will take you through that. So let me start sharing my screen right away so that we're happy with this bit. And if I come on to my full screen, there we are. And we have a bit of fluctuation here, but this is exactly what we were expecting. And we're organized on this. And do I have everybody on video? Are we comfortable enough? Are all the panelists now on video? And so we will start our panel discussion. And the sharing has now come on, and there we are. So let me introduce my panelists. We have, not necessarily in any order, we have Dr. Nitin Chaubal, who truly needs no introduction, one of our finest teachers, an analytical mind, a great teacher. We have Dr. Vatsala Dadhwal from the All India Institute of Medical Sciences, New Delhi. And we know that she is fantastic at procedures, but she's also wonderful with human beings and reflects great human qualities. We have Chander Lulla, who always has such exciting images to show us and makes sure that we remain challenged and constantly keep looking. We have Dr. Manikandan, who is perhaps new to some of you, but he is, what should I say, a legend of tomorrow, a background with Dr. Suresh, and then a fantastic foreground from Pondicherry. And he is innovative, he is incisive, he is decisive, and a great academician. And I'm so pleased he's on the panel here with us today. We have Dr. Ratna Dua Puri, the legendary geneticist. We know that she's just a phone call away. Sometimes we're impolite and call her many times. But thank you, Dr. Ratna Dua Puri, for always being there. And we go right ahead with our first case. We have 4 cases to discuss, and we will keep the chat box also open, but at the end to answer your questions. I know that's a bit of a limitation of the virtual platform for now, but I know that in the next few months, we will return with instant questions. And so if I go right ahead, the messages that we hope this panel discussion will take to you are that the 11 to 14 week scan is the best window for the assessment of aneuploidies, but rules should be followed. And you've heard a bit of this already, that several structural anomalies are evident at 11 to 14 weeks, and we need to evaluate these for a genetic basis. And so we must be sensible about this, that some structural anomalies override the aneuploidies risk calculations, and we will discuss this at length, that algorithms exist, and you saw some of them in Rabih Chaoui's talks, and we must respect those, and we must be systematic, because we need to take the next step, and that's for a complete diagnosis, that's for a prognosis of this pregnancy, and importantly, for the implications for future pregnancies. And the message that we love to give you from the Society of Field Medicine, that it's not that every structural anomaly or every ultrasound finding needs to be terminated. It needs to be evaluated. That might be a leader of tomorrow or a good citizen of tomorrow. And we have to change our approach and give every fetus an optimal outcome. And this window helps us to think. It gives us time to think. We're going to start with some background questions. And when I say background questions, the very first background question is here. And that is for Dr. Manikandan. If you look at my slide here, I want you to comment on 2 things. One is, would you agree that the first trimester combined screen is the most widely accepted and reasonably reliable method for screening for aneuploidies, which means maternal age plus NT plus PAPPA plus free beta HCG as a population screening method. But would you also agree that in the economically privileged patient, and a large number of us are now in private practice, either because of age or because we have fancier habits. So in that group, should we offer them an NIPT and a first trimester combined test with a PLGF for a P-risk calculation? Or would you have any suggestions on this?
Thank you, sir. I hope I'm audible.
Yes.
Okay. Regarding the first question, yes, ideally, I should say this should be the most widely accepted and dismissed, but with the qualification that it should be done by an accredited operator with an accredited lab. What it means now is that everybody starts reporting some kind of an NT, and every lab has a software that calculates. So it's not like you can do it without practice or some kind of a standardization. So it should be, but it should be standardized, and what the FMF gives, we should all follow. Therefore, we can also say that the results will be like what the FMF expects out of the screening. Right. I agree, but with some qualification.
Yeah, we will discuss as we go. What about my luxury option?
Okay, that for me seems a little bit of an indulgence, because when you do a proper combined screening test, and if the cutoff threshold is 1 in 2,500 or better, that means 1 in 2,000, 1 in 3,000, 1 in 10,000, then the negative predictive value of such a test is same as NIPT. And this will be there in about 80% of the cases, because ours is generally a low risk population for Downs. And so when you say blanketly for any economically privileged patient, I would still say that's a bit of an indulgence. If the patient wants, yes, but I would still say a very good combined first trimester screening with PLGF should be okay. Because when we take a cutoff of 1 in 2,500, that achieves the same thing as what you're suggesting here.
So would you then suggest that we give them a cafeteria approach? We let them know that, look, this much is possible with this, and we could do it as a two-step. Or if you think that money can buy you everything, then perhaps you can also take this option.
I for one, strongly believe in a protocol-based approach. So there is a program, and the program is a combined first trimester screening with a few exceptions. And this combined first trimester screening, if they are okay with that, then they undergo that. So I don't really encourage a cafeteria approach.
Okay. We'll come to more of that during the case discussions. And my next question is for Dr. Vatsala Dadhwal. If the NT is excluded from our first trimester risk assessment, then what is the detection rate for trisomy 21? And is this acceptable?
Good afternoon, everyone. No, just using beta HCG and PAPPA for detection of Down syndrome is definitely not acceptable, because the detection rate is around 60% with a 5% false positive rate, which doesn't meet the standard for a screening test. That is, you should have at least a 75% detection rate for a 5% false positive rate. So definitely no, NT has to be added to make it a good screening test in the first trimester. Although I think people are talking about adding more biochemical markers to PAPPA and beta HCG to make it have a better detection rate in the absence of NT, but those tests are still to come. But again, they may have a better detection rate, but very high false positive rates.
Wonderful. Thank you so much for that crisp, clear message. My next question, and this particular question is for Dr. Nitin Chaubal. What are the real world problems with NT evaluation? Mani had touched on these briefly. But we have these charming images here, and all of them are wrong.
Yeah. Yeah.
And
So good afternoon, Ashok. Can you hear me?
yes, very clearly. Thank you.
Thanks. So basically, I mean, we do have a lot of real world problems. Though this looks like a very good screening test, there are real world problems. The first thing is, of course, training. Though now we have a lot of people being trained, but I think this training has to be percolated right up to each and every corner of the country or the world. So that is very important. Second is following guidelines and protocols. As Ravi also said, if you follow protocols, you are going to do things better. So I think following guidelines, following protocols, and having some sort of an audit is something which is required, which is not seen as of today in a lot of areas. The third is real world problems. Like, for example, you have a fetus who is not in the right position, and as you just mentioned, you get frustrated, you send a patient, you ask them patient to come back. Ravi always does it in the same day, but sometimes you do have to call them next day. Then you have problems like obesity, and then the timing. As he himself said, if you do it a little later, 13 plus or something, you are seeing many more things. Whereas if someone is referred just at 11, you are going to see less things. So these are other things which come up. And in a lab, in a diagnostic center, typically like us, one more problem which we encounter very often is that patients are referred for NT at one place and the biochemical test is done at some other place. So integrating both can become difficult. So these are some issues which come. I think the main thing is training and having good protocols and taking good sections and having an audit. That is
So
what
we should be able to let people know that this is a fetus here that is just not magnified enough and completely off midline. That the chin is touching the chest here, and I see the entire zygoma sitting here. This is not even midline. And this one looks very good, but the calipers are wrong. This is a CRL and not an NT image. And here again, the calipers are wrong. So there's so many things that we must be sensible about, like you said. We just have to be careful about quality. And my next question is for Dr. Chander Lulla. Should I do everything? I know that for a population screening, as we heard, the NT is great. But when we add these additional parameters of the nasal bone, tricuspid flow or ductus venosus flow, how do these change the stratification into low risk and high risk?
Yeah, Ashok, there are three things in this. One is, of course, if you've got a borderline nuchal like 2.5 millimeter, the addition of ductus and tricuspid does help to evaluate for cardiac disorders. Number two, if you are in the intermediate risk group, which is 1:100 to 1:1000, if you've got any other positive marker, then it improves the detection of aneuploidy and you're immediately high risk. And the third is that if your biochemistry is not strong, I mean, you know, you're transporting samples and there could be errors in biochemistry, then it's a good replacement even for biochemistry to add ductus and the tricuspid valve in addition. And fortunately in India, everybody is well trained in ultrasound and everybody does it all at the same sitting. And this then improves the detection rate almost to 93 to 96%, as you have shown, coming very close to NIPT with a very low false positive rate of about 2.5%. So definite distinct advantages in different settings like a borderline nuchal, intermediate risk, and if you have good ultrasound, because these are difficult markers to do and you need some training. So if you don't have that kind of training, it's better to stick to combined screening, NT and biochemistry. But if you are trained well and it's not difficult to train, then this will add and reduce your false positive rate.
That puts a lot of marvelous things in perspective, Chandra. Thank you for that. My next question is for Dr. Ratna Puri. How can we achieve quality control in the evaluation of the biochemistry? We touched on this briefly when Dr. Manikandan was answering some of our questions, but what is your opinion? How do we achieve this?
Good afternoon, everybody. So this is tough because this has to be done really at the laboratory. So first I would say it has to be done at the user level and then at the laboratory level. The user level must understand what is the basic information that is required to run these tests. So you need a date of birth, which is the actual date of birth. Lots of people have official dates of birth which go into record. So that will make your test the risk estimation inappropriate. The correct weight. If you have the correct data about the pregnancy. Is it singleton, twins, the kinds of twins? If it is an IVF conception, make sure you say whether it's a donor egg, when was the egg extraction, when was the egg transfer. All these things make a lot of difference. Then we go on to the lab level. At the laboratory, there has to be a pre-analytical check, which means that the lab also will do a second check. We are all humans. So if one has missed something or made an error, then at the second level, we pick up the error. Is your blood sample okay? Is the vial all right? Are all the details there? Is the gestation correct in where you are doing that specific test? If you get in a test at 4 weeks and 2 days, you will not do either a triple or a quadruple or a first trimester. You will say, well, at this gestation, we cannot do the biochemical screening. Then it comes into the various lab parameters. The labs who are doing these, I think it's very important for the physician to know which laboratory you're sending it to. You should have confidence in that laboratory. Are they running controls every day? Is to make sure that the instrument is running okay? Are they maintaining the adequate ambient temperature and the humidity at which those samples have to be run? Are they involved in inter-laboratory control, or what we have, the EQAS, which is the external quality assurance schemes, which gives you a certain amount of confidence that the lab tests are coming out okay. And of course, last but not the least, but most of the labs are accredited. So I think these are some of the points which would help in some of our quality control as far as the biochemical markers go. Very similar to the ultrasound markers, I would say.
Thank you. And with that background, we now move to our cases. And our first case is the 23-year-old primate who presents for a first scan at 12 weeks and 1 day. And ultrasound reveals a single live fetus with a crown rump length of 64 millimeters and a nuchal translucency of 3.4 millimeters. And at this point, before I give any further information, I want a critical evaluation from Dr. Nitin Chaubal on whether this is normal.
Yeah. So normally, of course, we would correlate the NT with the CRL. As you conclude that this NT of the CRL of 6.4 or something is definitely much above 95th percentile. For all practical purposes, once you have an NT of something like 3.4 or 3.5, it is going to be not only above 95th, but it is going to be definitely above even 99th percentile. Therefore, this is definitely an abnormal NT as far as this scan goes, and this scan, as far as the sections are concerned, look quite okay. The amnion is seen separate. So this is definitely an abnormal NT for this fetus. So
wonderful. That is so nice and straightforward that we must look at a chart each time. My next question is for Dr. Chander Lulla. And Chander, what are the additional ultrasound features which would constitute a complete assessment?
So as I said earlier also, when there is an NT, the first, and in very well elucidated in Rabih's lecture, you look for cardiac abnormalities directly or indirectly, and other structural abnormalities. So we've already looked at ductus and tricuspid to evaluate whether there's any increased risk of aneuploidy or a cardiac pathology which is lurking around. But the most important thing I would like to stress is that you need to do the two views of the heart, as Rabih pointed out, the 4-chamber and the 3-vessel, because importantly, cardiac abnormalities can lead to nuchal edema. And then you will do a structural anomaly scans. If there's something very obvious, it will pop up. But at other times, if something is not very obvious, like a congenital diaphragmatic hernia, you need to look for that cardiac shift. You need to look for the femur bone length, as he just said, to see that lurking structure, skeletal dysplasia, or the fetal brain for any other abnormalities. All in all, we do a complete ultrasound evaluation along with Doppler, and also look for the absence of the ductus venosus, the direct insertion of the umbilical vein into the IVC. Will also need to be looked for no-nuns and other conditions.
So excellent. That means a complete systematic evaluation along with additional markers, if I may summarize that.
That's right. Yeah.
Now, Mani, for those of us who are still new to the subject, what are the causes of an increased nuchal translucency so that we can widen our thinking and our horizon? Mani, you have to unmute yourself. You have to unmute yourself. Yes. Thank you.
You have actually presented the various causes of increased nuchal translucency. Firstly, how my approach will be based on the assessment of the baby by ultrasound and a detailed pedigree. As you have pointed out, the most common will be chromosomal abnormalities, and then the ultrasound itself will give us a clue whether the next common, which is cardiac defects, are high in the possibility. Pulmonary in the first trimester, maybe I think possibly diaphragmatic hernia or some kind of increased pressure within the thorax, for example, in skeletal dysplasia also. Congenital infections are low on my list, especially in the first trimester, high NT congenital infections, though mentioned in textbooks, it's very rare. And metabolic, yeah, if there is a family history of storage disorders, perhaps, but that is also very rare. What can be there is a single gene disorder, especially if we have excluded chromosome, cardiac, and skeletal dysplasia, and let's say diaphragmatic hernia. Then single gene disorder, especially Noonan, is known to have about 10% occurrence, but I will not open my mouth about single gene disorder at the first sitting.
Wonderful. So we have a working list. We stick to the working list, but we have our priorities. Now, my next question is for Dr. Vatsala Dadhwal. NIPT, FISH, QFPCR, microarray, culture with karyotype, double marker, or anything else. What would be your recommendation?
So, like already discussed, the first thing that we have to rule out is the chromosomal abnormalities. Double marker, definitely no. With that, NT, doing a combined screen will anyway come positive. So it's no point wasting time and money on that. The best is to offer a invasive to do a karyotype. A microarray may be added after sort of counseling the couple that it may add extra information in 4% of the cases. And QFPCR may be done, it will give you a faster result, but again, then it has to be supplemented with culture because it's not going to give you all the chromosomes, the common 21, 18, 13, X and Y it looks at. NIPT, if the couple or the patient is not willing for an invasive, NIPT is the second choice. But again, here, NIPT doesn't look at all the chromosomes, although it looks at the most common chromosomes which cause all these chromosomal abnormalities like 21, 18, 13, X. So if they're not willing for an invasive NIPT, yes, with the rider that it may still miss 2.5% of other chromosomal abnormalities. So that is how we need to counsel and let them accept the test, but definitely invasive is the best way out.
Thank you. Now, in this situation, we had a CVS, and it showed us a normal QFPCR, a normal microarray, and Nitin, what would you do next? What would you recommend for this patient as a follow-up?
So if you have done an invasive, and the first step is, of course, as you said, QFPCR microarray is a good combination to start off. And if that is normal, that means our question has not been resolved. So the first thing I'll do is ring up the lab and I'll tell them you stored the DNA. That would be my first step. And then, of course, I would follow it up. And follow it up, especially for any evolving anomalies, follow it up to look if that nuchal is turning into a nuchal thickness which is more than abnormal, or whether there's abnormal fluid collection everywhere. And of course, look at more than any evolving anomalies which are there. So if these two have been normal, I will ring up the lab, tell them to store DNA, and then do a follow-up and look at the fetus. And depending upon what we see, then we'll decide what more to do.
Terrific. So this is what we did. And she came in at 16 weeks. Because we said, look, we've excluded aneuploidies. We have to move on to the next window. And we need to keep an eye on you. And she was very cooperative. And at 16 weeks, she shows a 4.2 9 millimeter nuchal fold. Certainly a little more edematous than I would be happier with. And she also shows me a pleural effusion, and we confirm it because I love doing 3D and looking at things for sure. And I just wanted to make sure there wasn't anything pericardial. There was nothing further. Further genetic evaluation, we had some of that DNA left over, confirmed that this was actually a Noonan's. So the only clue we had here was the fact that a follow-up was suggested. It was done at the right time. We were lucky enough to spot an additional sign, and we got an answer. And for the last question on this case, Dr. Ratna Puri, how is Noonan's assessed genetically? Should all nuchals be assessed in this way so that I can look smart to my patient and to everybody else? Or is there economics and genetics and logic behind this? And what is DNA storage that we just referred to?
Okay. So I just want to mention that Noonan syndrome is not one, Noonan syndrome is one disorder, but it comes as a part of something that we call rasopathies, because all these abnormalities are within a pathway. Everything in our body is in a pathway, and this is the MAPK pathway. So that's why the whole cohort is called rasopathies, and clinically they look very similar. So it is extremely difficult, by an ultrasound to say, well, does this child have Noonan? Does he have cardiofaciocutaneous, or does he have Costello, or which is the gene? So all in all, we have about 16 to 18 genes, and the numbers keep changing, which can cause disorders within this cohort. Now, there is a lot of data. We've gone through many criteria, though there are no guidelines for testing for Noonan. But there are two beautiful papers in 2019 and 20 of large cohorts, one in the UBOG, Ultrasound and OB-GYN, and one in the Journal of Medical Genetics. The latter one actually looks into all the phenotypes of 424 fetuses with Noonan. So that's a big cohort for prenatally diagnosed Noonan. And they say that if it's an isolated NT, then usually more than 5 millimeters, more than or equal to. If you have a smaller NT and you have one associated abnormality, as you had in your case, pleural effusion, or you have hydrops, polyhydramnios, cardiac defects, which are usually either a pulmonary abnormality or a cardiomyopathy, which you may not pick up so early. I agree with that. But if there's anything like that, then you go in for the testing. How do we test it? Like I told you, there are many genes. One is a common gene, 50% cases is PTPN11. The other genes, so I would prefer to do it within a rasopathy panel. But what is most important, which I really want to bring out, is remember there is black, you have an abnormality, it's a reported mutation. There is white, there is no abnormality. But in between, we have areas of gray, where you identify a variation of unknown significance, and you don't know how to take that forward. In my head, I think in prenatal testing, we should not report a VOOS. We should only report something that is pathogenic or likely pathogenic. The mutations are of different kinds. Because when you have a variation, which you don't understand the significance of, it's very, very difficult to counsel patients, and it can have effects or, implications which are not very happy in prenatal period, because you really don't know what the baby has. So, that is just a message I want to give, that just don't take any report that comes your way as an abnormal report, and you guide, counsel the parents accordingly. And the last question is, what is DNA storage? So normally in prenatal samples, you either have a chorionic villus or you have amniotic fluid. We cannot store these samples for long. All these tests are based on DNA. So DNA is extracted out of, either the fetal fibroblasts or the fetal cells that are present in that specific sample, and it can be stored in the lab for years. So ideally, when you do a chromosomal microarray, most labs should not ask for a different DNA storage, because automatically that DNA is stored in the labs and you can go back to that DNA at any point in time. I mean, my lab stores DNAs for 5 or 10 years because patients with genetic disorders die. And very often you want to go back to that DNA and test. So it is the same with most other labs.
So thank you for that. So the one question that the patient always asks me is that, so what is this gene panel you suddenly come up with? Why was my microarray negative? What should be the correct answer for this?
So, we have 2 kinds of genetic disorders, chromosomal and single gene. The microarray looks at only chromosomal disorders because that's the extent of the magnification of that test. Within those 23 pairs of chromosomes, which are looked at by the microarray, I have 20,000 genes, and I need to do gene panels where if I'm looking at a specific phenotype, I will only look at 18 of the 20,000 genes. So they are 2 different things and cannot be tested as of now by the same technology. Very soon, we're going to come up with genome testing where, we can look at chromosomes, del loops, SNPs, everything together, but it's still way off.
Thank you.
Ashok, can I ask a question?
Yes, of course, Chander.
Dr. Ratna Puri, the detection of Noonans with clinical exome is about 60 to 80%. Should we move to whole exome sequencing when we are strongly suspecting a Noonans?
Or whole genome for that?
Or whole genome, yeah. Because, many times you get a strong suspicion in the clinical exome is normal for a Noonans panel.
Yeah. So the way I would go about it is go back into the clinical exome, see are all our genes of interest covered up to 100% in that clinical exome.
Mm-hmm.
If usually we don't get deletion duplications, but if we have, so most of these are heterozygous, they're not biallelic, it's one mutation. I can pick up heterozygous deletion duplications when I look into the raw data. So you go back to your lab and ask them, are you looking at that? Remember, there is still a small cohort of Noonan where I've not identified the gene as yet. Okay, so that also becomes important. I would do a whole exome, but a whole, it depends upon the coverage of your genes. If I'm looking at an X number and they're well covered, it's fine. But it could be another look-alike syndrome, which you might pick up in a whole exome. That would be the only advantage of a whole exome. Or tomorrow, if there is a new gene that is flagged off and it's there in your whole exome, you get notified.
And can we do away with the CMA and do a clinical exome straight away to save time? Because deletions and duplications will anyway be picked up on the clinical exome?
No. So we are talking about no deletions
when we
and
have
duplications.
We are having a nuchal edema. Do we necessarily have to do a CMA or go straight for clinical exome? Because clinical exome can also pick up deletions and duplications.
No. It cannot pick up chromosomal, large deletions and duplication.
Okay.
If I have, 2 nucleotides or 5 nucleotides or 10 nucleotides that are deleted, it'll pick that up. But it won't pick up large chunks that are picked up in a microarray.
Okay.
Thank you for that clarification. I am now so well informed. And we move on to our next case. And that next case is this primie who comes in at 34 years and 8 months of age. She's 12 weeks and 5 days pregnant, and she needs an early morphology scan. I love calling the 11 to 14 week scan as the early morphology scan. She's had a dating scan at 7 weeks, 4 days, and that was equal to dates. And the scan now reveals an isolated, persistently larger fetal urinary bladder with a height of about 11 to 12 millimeters. The fetus is alive, 71 millimeters in crown rump length, a very neat, clean NT at 1.1, a beautifully seen nasal bone, a neat ductus and no tricuspid regurgitation. Kidneys look very nice. The viscera looks very nice. The skeleton looks perfect. It's really a nice, clean scan. Dr. Chander Lulla, what is a normal urinary bladder at 11 to 14 weeks? How is megacystis defined? What are the implications of a megacystis? And what else would you like to look for at ultrasound?
Yeah, so we had Rabih telling us beautifully that bladder less than 7 millimeters in vertical dimension is a normal bladder, and you need to see it more than 7 millimeters to call it megacystis, provided you see both the iliac arteries around that cystic area and you confirm that it is a bladder. So when you have a bladder which is more than 7 millimeters, we tend to call it megacystis. The implications are twofold, and it would depend on the size of the bladder. So anything between 7 and 15, he just elucidated, there's a higher chance of aneuploidy and a lower chance of obstructive phenomena, and a very high chance, almost 70% chance, that it may disappear on screening, further screening. And that is what we should do when you have a bladder which is distended up to 15 millimeters. If it is beyond 15 millimeters, then is a very high chance of having an obstructive uropathy, either urethral agenesis or a posterior urethral valve, and a lower chance of having an aneuploidy. Now, in this particular case, of course, you said the NT is 1.1, but if otherwise, we would look for all the other soft markers, like an abnormal NT would suggest trisomy 13 or 18, which is the common cause of megacystis. You would look for an omphalocele to look for an OEIS syndrome. You would look for the spine to look for vectoral abnormalities. And if your bladder is twice, you multiply the CRL in millimeter 2 times, and if your bladder is as large as that, then even a cloacal abnormality can be expected. So you again look at the whole spectrum of the fetus structurally, and that will give you the final diagnosis. But most important to highlight is that a fair percentage will disappear over a period of time and will regress, even if it is up to 15 millimeter. So you do offer an invasive diagnosis in the form of a CVS to confirm if there's no aneuploidy, if it is more than 7 millimeters, and then you take it there from there as a follow-up.
We had some papers that came around Christmas 2018 and got published in March 2019 from Katia Bilardo's group. And there, Federica Fontanella said, look, use 12 millimeters. Yes. And also look for umbilical cord cysts and whether the nuchal is normal. And yes, that might be a better idea as a cutoff, the 12 for a bad prognosis. Yes. What is your experience with this, or do you still stick to the good old time-proven stuff?
No, I do stick to the 715 stuff. Umbilical cord cysts, we've seen a few, but I have not seen that kind of correlation that Katia Bilardo's paper has shown, that there is a higher incidence of posterior urethral valve. So we do take the 7 to 15, do the aneuploidy screening and follow up. Because at this stage, anyway, you are just counseling the parents. So whether it is 12 or 15, it doesn't really matter. You're telling them that it's a little large bladder, and you're always trying to be positive and tell them that this may regress. Unless if it is larger than 15 millimeters, then you're a little worried and you will call them back in any which way.
Terrific, thank you. Dr. Ratna Puri, what's the role of biochemical screening once we have a finding like a megacystis? And then while we were trying to counsel her and going more and more into her history and cell phone calls with her mother-in-law, etc., and her mother, she says she has a first cousin with trisomy 21, a nice straightforward 47 chromosomes, not the translocation type, but she's anxious.
Okay, so typically if there is trisomy 21 in a cousin, it does not increase the risk of this lady having a child with Down syndrome over the baseline risk, because trisomy 21 is a chance happening. It's a non-disjunction, so it's not inherited. As long as there is no family history, and I am sure that this trisomy 21 does not interfere with her risk of aneuploidy in the current pregnancy. But in the presence of a structural malformation, I think, as we've already discussed before, there may not be too much role of biochemical screening, because you would want to know the chromosomes of the fetus. Because if there is an abnormal number, mostly or sometimes a structural abnormality identified, then the outcomes are different compared to when the chromosomal complement is normal. So I would not really go in for a biochemical screening. And this family history would have no implications for the current pregnancy.
Thank you. So we will stick just to the megacystis as a finding, and we would then counsel her accordingly.
Yes.
Dr. Vatsala, what options will you give her?
Like we just discussed, because she has bigger sisters, and the ones which are less than 15 oblique 12 mm are more likely to be associated with chromosomal abnormalities to the tune of maybe 20 to 30%. So an option of invasive can be given to her for a karyotyping.
And what about if she doesn't want invasive? If she's insisting on an NIPT because there's so much hard sell on NIPT, what would you tell her?
She could go for an NIPT, but that will look at the common chromosomes, which are usually the commonest cause for this kind of abnormality, like chromosome 21, 13, 18. And there is a small chances of missing other chromosomal abnormalities if they are there. And if the chromosomes are normal, then the chances of regression are very high, almost like to the tune of 90%. 10%, there may be a risk of developing a obstructive uropathy for which we'll need to follow up.
And if she's terrified of any invasive testing, of course, then you will say, okay, 16 weeks is another possibility. Would you include that in your counseling?
Well, if she's not willing for anything at present, you can follow up and see if it resolves or the lesion is progressing or you find additional findings. Because if it is progressive, it has become bigger, or there are other associated anomalies that you see in a 16-week scans, then doing a invasive becomes more stronger. The indication for invasive becomes more stronger.
So unlike an NT where the risk does not disappear if the NT settles by 13 or 14 or 15 weeks, or the nucleedema settles by that time, the resolution of a megacystis would mean very encouragingly that we are headed towards normal.
Probably, yes.
Yes. So she was offered all of this and she opted for invasive testing. And a bit of a surprise there. We got a FISH positive for trisomy 21. And it was nice that this worked out right. Otherwise, we know that we would have picked up something more, of course, at 16 weeks. And then, of course, that sort of sealed the deal. Now, Dr. Manikandan, when we get this kind of a result from a FISH positive at trisomy 20, what should be the counseling now?
Okay. Okay, so we have to reveal the bad news for the mother. And there is a phenotype, and then the FISH, we talk with the lab also, and we ask if they are absolutely sure. Then we reveal the diagnosis that the baby, the fetus has Down syndrome. In my practice, I actually call up the cytogenesis and ask for an expedited release of karyotype, full karyotype also. And based on that full karyotype, further counseling, especially with regards to recurrence, will be done.
Wonderful. So counseling pre-test, counseling post-test, counseling intra-test. Would you agree that counseling is an ongoing procedure?
Yes, fully
Wonderful.
agree.
So she was actually very grateful that we found this, and then she's been following up since then. She's had nice, good babies ever since. And we move on to our third case.
Sure, can I make a comment?
Yes, of course.
You asked about prune belly. The only case of megacystis which I had, which turned out to be prune belly, I just couldn't see the anterior abdominal wall. It was almost as if the fetus was stuck to the placenta. And when we did it, the termination, they found that it was a prune belly. So a very large bladder where you just can't see the bladder wall.
Yes. Yeah. So that brings us to, thanks for that, a 35-year-old patient, and she conceives after IVF for a tubal factor. And early scans reveal a singleton pregnancy. She has a first trimester biochemistry at 10 weeks, a PAPPA of 0.64 MOM, and a free beta HCG MOM of 1.76. And a scan at 12 weeks reveals a normal growth. And apart from that normal growth, the crown rump length corresponds to 12 weeks, 2 days, a nuchal translucency of 2.78, a visualized nasal bone, a normal ductus, and no tricuspid regurgitation. Her risk for trisomy 21 with biochemistry NT and the additional markers is 1 in 274. And a scan at this time shows omphalocele, which contains bowel and a single umbilical artery. And we worked pretty hard to make sure there was nothing inside. You know, a lot of these patients are very resistant to vaginal scanning, but we did get information. Finally, we convinced her that she needs one. We had to show her the omphalocele on the 3D so that she could get convinced that the tummy doesn't look like a tummy and so on. And finally, she says, okay, now what next? So, Dr. Nitin Chaubal, what is the current status of accuracy detection of fetal anomalies at the time of the nuchal translucency scan? Rabih did touch on this, but could you summarize that for us?
So that's right. So I mean, we have different populations. We have different studies. By far and large, we are, overall, if you look in a high-risk population, we are touching figures of 60% all over. And in low-risk, of course, they range between 30-40. But by and far, if you look at most of the studies which are coming up, we are in the range of now close to 60%, especially in a high-risk population, especially for looking at major anomalies. And of course, as you said, that when it comes, it also depends upon the anomalies like acranias and holoprosencephaly, abdominal wall defects like this omphalocele, megacystis, which we just discussed. Things like this, we are almost reached 100%. And we are trying to bring in more and more anomalies, more of cardiac, CDH, etc. into the first trimester. So overall, I mean, we have figures which range between 40, 60. There are some reports of 70, but 60 would be a sort of a working figure for accuracy.
Wonderful. So, Dr. Vatsala, what should the patient be counseled about? You'll have to unmute yourself, Dr. Vatsala.
So this patient has all the high risk factors for having a baby with a chromosomal anomaly considering her age, intermediate risk for her biochemical and a gross malformation like omphalocele, especially a small one with the bowel only. And so she'd be counseled for invasive testing for a complete karyotype.
Which is exactly what was offered to her. Dr. Manikandan, this patient refused invasive testing. Now, legally speaking, should the patient's clinical notes, you know, when we write them down, consist of mentioning the finding and writing all this down, and do counseling summaries need to be signed by the patient and a companion and so on? How should we handle this from a medical legal?
Definitely. Yeah, definitely we should document that we have explained to them in plain language also, and document what we have explained, and it should be within the clinical notes that within the report that we issue. It is also a good practice when we offer an invasive and the patient refuses, or when we offer even Down syndrome screening when the patient refuses, that the offer has been made and the decline is from the patient's side. So it's better to document and get it signed, but sometimes getting the sign might look like very defensive practice. Legally, if you have written down something, it's assumed that you have explained. So legally, that's enough.
Excellent. Thank you for that clear, straightforward thing. But she still was not convinced about invasive testing. Dr. Ratna Puri, this patient goes home. And then she wakes up about 2 weeks down the line and she says, what do I do? And like all patients, she says, okay, forget all the radiologists, all the obstetricians, I will go straight to genetics. What are her options now? Dr. Ratna Puri, yes.
Apologies. So we are dealing so far with an isolated omphalocele as per the first ultrasound.
And a so-called single umbilical artery. Yes.
Yes, and so-called. Now, she's nearly at 16 weeks. To help her, I know in my head that an invasive testing is required. But obviously, she's not ready for it. So how do you work with the patient? You say, okay, let's do one more ultrasound. Let's see how your omphalocele is behaving. And when the omphalocele is there, maybe there is an additional marker that will further convince her to do invasive. So you're clear what you want to do. You just have to get around the patient because that patient is difficult. She's worried, you know. This is something which is a denial, which we face very often. The denial that my baby can have an abnormality and I'm not willing to accept it. So she's already had some time. I would reiterate the fact that an invasive would be required. Re-examine for additional abnormalities, because we also know that beyond chromosomal, there are other things, there are other single gene syndromes that we are looking for. And if more or less we can look at things and it remains to be isolated, then they have the option of taking it forward and having surgery done. You can say that there's a slightly increased risk of IUD. There's a slightly, even if you get surgery done, it has its implications. I would put her in touch with a pediatric surgeon to help us out. But I would still want to look at the chromosomes.
Well, this young lady is still on a shopping spree. And she is informed by some very kind neighbors that there is a quadruple test available, and it's new. She comes in for a scan. There's no new finding. There is an omphalocele containing bowel. And she has a single umbilical artery. But she wants a quadruple test. At this point, while looking at things, we also discover a 2 millimeter muscular VSD. Now, she finally decides that, yes, I will opt for invasive testing. But before we go on to that, Mani, what do you think of this quadruple test being done after we've done such extensive workup already?
Okay, so this is a very common blunder that is seen in obstetric practice when there is a first trimester screening report which is done correctly and then going on for a quadruple screening test. It should not be done if you understand the principles of screening. A combined first trimester screening has a very high sensitivity compared to a quadruple test, and you can still have an affected baby with a quadruple test. So we don't offer it. Originally planned for an individual. That's a totally different issue, and in practice, most of us don't do that actually. So no quadruple test if you have already done a combined first trimester screening. Take an action on that. You either go for an NAPT or for an invasive, depending on the situation. In this case, of course, invasive, because there is a finding on scan.
Yes, and we reassured her that, look, it's IVF and no IVF. Would you like the options of a child with a disability? Is this acceptable to you? Some people in the world would never think of a termination, and that's the way I always start off, by talking. And then we sort of tell them what the real world is about and how harsh and crude the world can be. So she did opt for invasive testing, and the QFPCR confirmed trisomy 21. I did feel awful for her, but the fact is that some patients will take their own time in spite of the bonding. In fact, they start bonding the day they get their urine HCG positive or their serum beta HCG positive. But we still have to follow all our rules. And of course, the other lesson we learn is that we just keep calling them back till we add more evidence and we're able to convince them. The patient has a right to decide, but our counseling should always be appropriate. I just saw Nitin looking at his watch. I know we're running about 10, 12 minutes late, but we decided at the beginning that we bought time all the way till 7 o'clock.
Just out of habit.
The feedback from our attendees, they asked us to go a little slow on genetics because they all wanted to consume all of this. We've almost answered many of their questions already, and we will answer some in case 4. The odd 4 or 5 that are left we might even keep for the end of the day, but let's see how much more we can answer, because there's a lot of them that have already been answered. So let me move on to case 4. And this is a 32-year-old primie, and she comes in at 12 weeks and 4 days with the first episode of bleeding per vaginum. She has a crown rump length of a singleton fetus of 45 millimeters, a heart rate of 181 beats per minute, a nuchal of 2.7, a nasal bone, which my colleagues love to measure. They said, look, if we don't have to measure it, we won't focus it if we don't have to measure it. So I said, okay, go ahead and measure it. And it was 2.4, ductus venosus, which was all right, and no tricuspid regurgitation. No major anomaly is evident on a transabdominal scan, but the visualization was not so nice because she had this delightful maternal abdominal adiposity. I mean, we do understand that adiposity has doubled 120% between 2000 and 2010 in the Indian population. And between 2010 to 2016, it has doubled to 160%, which means that from 2022, we will only have obese patients and nobody else. I shudder to think what's going to happen, but hopefully Corona will help us lose some weight. Now, she had an early transvaginal scan at 8 weeks. CRL at that time was 15 millimeters and a heart rate of 141. So my first question is for Dr. Vatsala. Is this a growth restricted fetus? Can fetal growth restriction manifest as early as this? And what's the usual list that we start thinking of when we find this finding?
Yes, it looks like a growth restricted fetus, and growth restriction can occur even in the first trimester, especially if there is aneuploidy. Because when you look at the first scan, the CRL is more or less corresponding, but the 12-week scan is showing a CRL of 45 mm. So there is more than 5 to 7 days lag. And it's been like seen that trisomy 18, 13 are usually associated with first trimester growth restriction. So they would have smaller CRLs. And here again, if you look at the fetal heart rate is also on the higher side, 180. So I think she needs a better scan. A very less chance of it being a constitutionally small baby, or sometimes you may have anomalies such that you're not measuring the CRL properly. So that could be fallacious. So these could be the rarer reasons, but yes, first of all, we should rule out aneuploidy in 12-week scan. Maybe a transvaginal scan to look at other anomalies would be good.
Wonderful. Chander, could you summarize the clues that Dr. Vatsala has just given us? And also let us know how you're thinking on how to handle this patient.
Yeah, so as Vatsala just said, there are glaring clues here. The CRL is more than 1 week smaller, so the cutoff usually is a week. And the moment the CRL indicates that the fetus is more than 1 week smaller, here as it is 45 millimeter, it should be about 11 weeks, and she's 12 weeks, 4 days. We immediately start thinking of either trisomy 13, 18, or triploidy. And with a high heart rate and a nuchal 2.7 millimeter, I would do a very detailed structural scan to rule out any other glaring evidence of any aneuploidy. As you're showing here, there is a holoprosencephaly indicating a trisomy 13 probably with a high heart rate. Trisomy 18 would have a slower heart rate, so a higher heart rate narrows it down to trisomy 13.
Yeah, and she was so used to, because of the abdominal obesity, we'd already done vaginal scans for her earlier. She agreed completely, because really there was no butterfly that we could make out when we were looking transabdominally. But then I don't know how much it depends on an image like this. And we know we're so used to seeing such nice butterflies these days. We did and go on to look at the cranium. It was a crazy cranium. There was an obvious holoprosencephaly. There was this proboscis sticking out. And I love the image, of course, from a collector's point of view. Very sad from the patient's point of view. There is almost nothing lying there in the mid-face. The face looks odd, the nose looks odd, the eyes look crazy. We know that this is a completely grossly dysmorphic facies. Dr. Manikandan, what is the likely diagnosis, and is there too much of a differential?
Yeah, as Dr. Chander said, the most likely diagnosis would be trisomy 13, Patao.
Right, and so CVS actually confirmed that finding for us, and that's what we found. And the finding was just straightforward, and we were picking it up on the fish. We confirmed it on the karyotype later. Of course, she had already opted for her termination. She didn't even wait for this, and that, of course, is the correct approach. So we have learned a lot here, and thank you so much for your attention so far. We have a couple of minutes which I've borrowed from Rabih's time to say that, okay, let's answer some of the questions that have come onto the panel, and we'll try and answer those while the panel is still here. And I'll take up the little question box now and say, all right, we will do that and say, the first question is this, that and this is from Dr. Raman Sharma, the biochemical marker tests and NT are done at different periods of gestation, and is it correct to integrate them on different dates?
Yeah, So when you do it within the acceptable limits and you have converted them into multiples of medians, then the software will accept integration even if it is done on different dates. The disadvantage is that when you do the biochemistry early without a scan, you might not get a correct CRL. So that's the disadvantage. But if you do it with a scan, then it's okay.
All right. Dr. Ratna Puri,
I just wanted to add there that even later, the CRL with the NT can be added to give out the final risk. It can just be entered into the algorithm.
And that's mentioned the group on which that was done. Yes. And could you also, there's a question from Dr. Sheetal Mehta. Are FISH and QFPCR for aneuploidies interchangeable? Does one perform better than the other? And is there a situation where one would prefer one over the other?
Okay, so they both are done. They essentially answer the same questions where we are looking for aneuploidies. Remember, it's a technology. You can do it for anything. But here we are talking about our 5 chromosome abnormalities of number, 13, 18, 21, and sex chromosomes, and can look at that. No one is preferred over the other. It depends upon the expertise of the lab where you're sending in the test. Another thing that I would also like to mention is that when you're doing a chorionic villus sampling, remember you have to do a maternal cell contamination. Once a sample comes into a lab, they do separate the villi from the decidua, but that's only under a microscope. Beyond that, it has to be done by a DNA-based test. And the DNA-based test that does this is very similar to one that looks for the aneuploidies. So you can do both together. So you have to just give maternal blood for maternal cell contamination. So it's important to understand that. Please don't ask in a CVS sample for FISH, for maternal cell contamination and a karyotype or a microarray, because that's wasting money.
Dr. Ratna Puri, can I ask you, the FISH requires more human intervention. It requires more human expertise, whereas QFPCR is more a machine-based test. So that's why it's easier to do and requires less expertise.
So it's like I said, it depends upon what the lab is comfortable doing. So remember, QFPCR is a newer test. FISH has been here for 30, 40 years, for many years, 30 years at least, and 25 really. So it really depends upon the expertise of the lab. You can go wrong in even interpreting QFPCR because you have to interpret the signals. Yeah.
Dr. Ratna Puri, while we still have you on our panel, what is the status of NIPT for microdeletion? This is from Dr. Niharika Malhotra Bora from Agra.
Okay, so as per the guidelines, it still says NIPT for the 5 chromosome. So remember, NIPT was really made for chromosome 21. The others just piggybacked onto it. That's why you can say that the sensitivity for the other chromosomes is much lower compared to trisomy 21. The recent meta-analysis really is fairly similar for 13, 18, and 21. But for the microdeletions, the positive predictive value is too low. It is very low, and I would not order that as yet unless we have more data. But referring to one of our cases where we thought that the patient just did not want to do an invasive test, and there was a malformation where we know that 22q can be there, then I would ask there, but I'm still not comfortable ordering NIPT for microdeletions.
Ashok,
it needs a lot more work for it to come into clinical practice. Yes.
So if NIPT for trisomy 21 is there, it is a little lower on the graph for trisomy 13, a little lower for the sex chromosomes, a little lower for the microdeletions, and really low down at the moment for my single genes. Is that the way I should look at it?
Yes. So there are some autosomal dominant disorders for which they worked out NIPT, but like you said, it's still low to be ordered right, left, and center.
So for instance, if I found a short femur at 12 weeks, should I do an NIPT for FGFR3 gene? I mean, we had literally talking about this 3 years ago or 4 years ago.
No, not as yet.
Yes, Rabih. Yes, Rabih wants to add to that.
Yeah.
No,
yes.
of course not.
No,
of course not.
Ashok,
Yes.
I would like to ask Dr. Rabih, there are some new NGS-based microarrays which are nearly 100% specific for achondroplasia and thanatophoric FGFR3. There are a lot of papers on that. And it'd be very useful at 13 weeks with a short femur or no short femur with a family history of achondroplasia to do an IPT. So what is Dr. Rabih's opinion on that?
Well, let's say we have published with Asma Khalil a sign what you can see on 22 weeks. But I never had the typical short femur at 13 weeks with achondroplasia because it is really at the 25th percentile at 22 weeks, starting 25, 26 weeks. If you have a history, because the mother or the father are achondroplasia, they have 50% inheritance. In general, these are the one accepting a child with it. This could be an exception to say we can do it, and you can publish it as a letter to be even more famous, Chander, but this is nothing. For thanatophoric, if you can wait for half an hour, it will come in my talk. And if I'm invited again to online, I can give you a talk on skeletal anomalies in early gestation. And you see this is, let's say the two things are clear, you can distinguish, but there are many other things.
Ashok,
I feel that for me is NIPT, I did not put it in my talk, in any of my talks, is abbreviation of non-informative prenatal testing in the setting of prenatal anomalies. If you find fetal anomaly, don't use it.
Marvelous.
But let's say, on the other hand, for Ratna's answer, I am a little bit in favor of 22q11 screening because you can, let's say the test I'm using, it's the Ariosa group, there is a detection rate around 70 to 75% detection rate. I'm not in favor in later gestation because you can use the thymus and so on, but in early gestation, you don't have a lot of signs. And people, let's say, honestly, if you look at us, the 1,200 people online, most of them will be able to detect trisomy 13. You have seen the holoprosencephaly and so on, and trisomy 18, but 22q11 is a challenge because you need to see the cardiac anomaly, the conotruncal one, and so on. So if you receive a result which is positive for 21 or for deletion, you say, oh my God, I missed this, it can be possible. But if you receive a result after having normal scan of trisomy 13, you come on, no go, no way, I saw or was normal. So this is why for me, the detection would be 21, deletion 22q11 for the future, the 70% cases, and then the other one with or without. 18 could be tricky sometime.
Thank you. And Rabih, while we're answering these questions, somebody wants to know up to what gestational age, this is Unmesh Bhosle, can we call it physiological omphalocele, 12 weeks, 3 days, 12 weeks, 4 days, 12 weeks, 5
I put roughly 50 millimeters. I put in my talk 50 millimeters, so 11 plus a few days. I know that with the high resolution probe, you can see it until 11 plus 3-4 days, but that's it.
Yes. And then, of course, there is also this question of trying to look, and we've already answered that, about kidneys and oligoamnios at 12 weeks and how we should handle that. So there was actually a question.
Again, there is only one condition you find less amniotic fluid. It is in serenomelia.
Yes.
This is the only condition I saw 3 times. So, and then there was little bit less. The other, even if you have real agenesis, you have normal fluid at 12 weeks.
And then there is this question which says, many people just stop looking at the nasal bone after looking at it earlier on. Is that logical?
Well, it depends where. If you are in China or Africa, you can say, okay, if you have, it depends on your setting. I still look at it. But Kipros, in one of his last talks, he was saying, you know, you should always consider in the setting of which condition. So,
yeah.
But you should not exaggerate and terrify. And I do exactly what Kipros was saying last week. I make a notice for myself and have a look later on. It was not described with other conditions, but if you see it, so then you can still look with another approach. The same for the ARSA.
Yeah.
What I teach people, Ashok, again, I say, you know, if a patient's come with an NIPT, either with a wish or she did it before, what happens today, every day? Should I do a genetic scan again? And what for? If the genetic scan is aiming for down, but you have 99% down, so it should be 3, 4, 5 hints, then you can say, well, I don't believe it. So, but in general, we should not be allowed to do a genetic scan after. It's like after amniocentesis for me. You doubt on the finding. No, be logical.
And we've all grown beyond that, don't you think? We look at the forehead, we look at the nose, we look at the lips,
Yeah,
we look at the chin. And we're seeing so much more in that same image all the way down to the nuchal. And it really makes no sense now to ignore that. I refuse to look at the nasal bone, don't you think?
Yes, I look at all. So, but you know, I put it always in the context what I'm seeing. This is why I don't. So, I write sometimes my report. No genetic scanning performed because the previous NIPT was normal.
Yes.
And then if it's not there, I will ask to see it. I want to see the fetal fraction.
And now, in terms of looking at the kidney, would you attach importance to the renal pelvis at 12 weeks? The AP diameter of the renal pelvis at 12 weeks?
No. I had both directions. Documented slightly enlarged, disappearing, and becoming a little bit enlarged later on. So it has, you know, the question is twofold. Is it 3? Is it going to be a renal anomaly? Probably not. Is it going to be a sign of aneuploidy? Isolated? Practically never. You need some additional things. If there are additional things, I will exaggerate on these. So if the fetus has a nuchal of 3.4, absent nasal bone, do you really need to describe the pelectasia? If it has only this, and it could be at 22 weeks, slight dilation leading to a control at 30 weeks and after birth, what to tell them at 12 weeks? Oh, I see something.
Oh, I see something.
So
yeah. Now, I want this answer to be coming both from Dr. Ratna Puri and from Rabih. Dr. Ratna Puri, somebody wants to know the cost of the gene panel for Nonans. And Rabih, I want you to tell me about this very interesting controversy we have in Germany, where the exome is putting as a micro.
The exome is paid, but not the array.
Yes, yes.
Yeah, I don't know. I cannot explain it still today. Probably when it was, I don't know. I'm not a geneticist, but I'm very involved because it's next door to our place. Probably because they assume that geneticists will use the exome really when they have a targeted known group of anomaly they want to seek for, which have changed today. While in the array, it is so like, if we do anyway an invasive, let's do an array on top, and it costs a lot of money. So they decided no. Even that from the legal point of view, you have to offer and to discuss array. Even if the patient has to pay on their own. But you know, I tell my patient, some patients say, I want to have as first step, I had several times. First step, I would do an IPT. But then later on, they do the amnio. I said, oh, but I don't have money to pay for the array. This is why at the beginning I said, stop. Don't do an IPT because only the Down syndrome condition is the one we can miss. Keep the money by side, the 300 euro, and put on top double to have some 1,000 or 3 times, and you can afford. Because if they start paying, it's not. And to Chander discussion before on the noon, and I was listening to you even if you haven't seen me. You know, the question is, do we really need to examine all possible things at 13 weeks? We don't do. We do a first in a classical invasive CVS, for example. If there are, let's say, substantial reason to do more, we do an array, and I wait until 16 weeks to see are there signs of other things. If it's the sign like the one case you showed with pleural effusion, we go for Noonan. If there is persistence of nuchal, we do for Noonan. But automatically doing Noonan. Now the question to Ratna could be, and this our geneticists are very conservative in this setting. If you have fetus having nothing and the nuchal is still present and it is Noonan and the baby is healthy, why should you know prenatally? why should you pay money prenatally to know it if the baby has nothing? On the other hand, if you have a fetus having severe edema, it will anyway die. Noonan, almost 98% of the cases are autosomal dominant. There is 1-2 genes which are recessive, but the other one are so accidental. So no need to know this unless you are seeking for the exome to know if it's some mucopolysaccharidosis and all these rare diseases. But these ones are recessive, and unless you do pre-implantation genetics, you don't need to know them. So because it will be anyway recurrent of.
So firstly, we follow a large cohort of children with Noonan syndrome, and majority of them do not have intellectual disability. And for me, that is very important. Like somebody said, and I think like the theme here is that everything abnormal need not be discontinued in pregnancy. And there are many, many families who opt to continue. I have a family who's opted to continue a child with Down syndrome. She's absolutely fine with it. At least there is intellectual disability there. But in India, we have different issues. We have issues of accessibility to occupational therapy, to multisystemic. All of these are multisystemic management, and it is difficult for these families, and they have to pay everything out of their pocket. But at the same time, I think it's very important that even with all these phenotypes of an increased NT, with say one additional abnormality like a pleural effusion, it's not necessary that it's Noonan syndrome. It may be nothing. It may be nothing, and then the baby is absolutely fine. So that is why it's probably important to do the test, because here still we are within that framework that most of our families would not want to continue with the pregnancy if we tell them that the baby has a genetic disorder. So it becomes important. The negative of it becomes important. Well, I've tested for this and we have not identified anything. Forget about the Noonan panel, even if we do an exome, that we have not identified anything that is known at present to be associated, at least with what we are looking at. But at the same time, like I said before, we have to be very careful how we report out these exomes. No variations of unknown significance. So counseling is very important. I have a family who had a VUS for one of the Noonan genes, and the baby was fine, but she became a little off because she tested in herself she had it. She tested it in her normal child who had it, because it was just not a significant variation. And for her baby who was born, for 1 year, she would keep calling me to ask me, would he develop a phenotype in the second year of life? So how we talk to these patients has very important implications. And I think we should not take any of these tests lightly, because interpretation is a key for these tests.
Bravo.
Can I ask? Yeah. Dr. Puri, you said that we will be able to say that it's not there. But we also know that, for example, Noonans, you can never be sure prenatally, even if the test returned as negative, that it's not excluded completely, right?
Which is why I said it's important to note. Yeah, sorry. You were finishing. You were saying something else. Apologies.
So, and when there was a large NT, and then so the possibility of Noonan increases. But when we counsel and then we do a test, a panel, the panel does not detect, and it later turns out to be Noonans. It puts in a difficult situation everybody.
No. So what is important to guide them is that we've looked at the genes. So typically what we do in India is the clinical exome. These are the actionable genes, all right? So these are the OMIM genes, which are OMIM morbid genes that are known to be associated with the disease. Tomorrow, if a new gene comes up, obviously you cannot test it. So it's important to counsel the patients and tell them that what is known to date in science, obviously we know nothing. We only know 0.2% of what we are all made up of. We just can test for that much, and that is what we are telling you. That becomes a very important part of talking to the family. I mean,
Chander,
we've had cases, we've done a follow-up of 200 babies with increased NT in pregnancy with array, and then followed them up till 3 months after birth, and we found a couple of children with other autosomal dominant disorders, PACS gene, etc. But you can't test for everything in pregnancy.
Exactly. Yeah, that's my point.
This is for
go ahead. Yes.
Rabih, in Nunans, it is said that the cardiac abnormalities may manifest late. So have you ever encountered Nunans where the cardiac abnormality was seen late in the third trimester?
Yeah. Typically
So
cardiomyopathy, you see 32
so it would
weeks.
be better to know at the second trimester that the baby has Nunans.
Okay.
The ethical problems there.
Let's say a short answer. I know we can discuss half day only on one of this. The short answer is simple, and Ratna said it. You need first to counsel and to ask if they want to, and you shall tell them the spectrum and the outcome. Because it's not the issue that I do, and I as a doctor will do all, and I will tell you, I don't ask you, I do it, and then you tell them this is the result. And say, okay, why should I have examined this? So the issue is the patient, the informed patient decide, yes, I want to do this testing. And some specialists on Nunan, we have one in Germany, one of the world famous one, could tell you from the mutation what could be the outcome of the child. Because we say Nunan, but it can be Costello, it can be CFC syndrome, it can be many of these groups. So it's not so straightforward, and it's called Nunan at the end. So this is why I'm not saying don't do it, but I'm not saying at 12 weeks you should start the whole battery. Wait until 16 weeks, do more scan, and then work on more.
So in the next 3 minutes, we will take 3 more questions. One I will answer quickly myself, and that is the interpretation of the nasal bone in people like people from Eastern India, the West Indies, the African races. What to do with the nasal bone? I think Rabih's already answered that question. We don't give it that much importance as an isolated marker, but we look at it anyway because we're looking at the whole face and neck. Now, the 2 quick questions for Dr. Ratna Puri. One is a termination on the basis of an NIPT positive, sensible or stupid. And the second question is diagnostic investigation of a couple at 12 weeks when the previous child has Down syndrome.
Okay. So the first one, remember NIPT is a screening test, no termination based on a screening test. You have to do the confirmatory test. So you either do a CVS or you do an amniocentesis, depending upon what period of gestation you are. I prefer amniocentesis because sometimes you get caught with CPMs on a CVS, so amnio is better. Second is previous child with Down syndrome. We must know what is the karyotype. So find out if it's a free trisomy 21, the risk of recurrence is 1%. If they are fine, you can even do a NIPT there. But if it's a translocation Down syndrome, and then you have to karyotype the parents. If the baby has free trisomy 21, you do not need to karyotype the parents, especially if there's no other family history. But if it's a translocation Down syndrome, then you do a karyotype of the parents. They may or may not be carriers. If they are carriers, then you have to do an invasive testing because when there's a translocation, there are 2 chromosomes involved, 21 and the other one on which the 21 has piggybacked.